Thanks so much for this opportunity. So I guess our project really looks at an extension of what Jackie's project has been doing. We have a lot of things in common around communication difficulties, around poor health outcomes for people with an intellectual disability. But we started off as a collaboration with ADAC and our local health district, looking specifically at the outcomes for people who live in supported accommodation. Why did we do that? Well, we had found that people who live in supported accommodation often present to hospital alone, with or without any kind of explanation about why they've been presenting to hospital, often after hours, via ambulance, and all the information there is about this person is that they've had a fall. Some disability service providers would provide us with what I call the filing cabinet, and you'd have 16 folders full of wonderful information that you could never find or get to, or a one-pager which was patently inadequate. Some of you may recognise the picture of the lady up here, Margaret, who is holding a picture of her daughter. It was a very sad story a few years ago that came to light in the media probably about 6 to 8 months ago, where a young lady had presented to an ED department here in New South Wales and subsequently passed away after having been turned away from ED. I'll touch base on later on as to why she was turned away from ED. But this is not an unusual occasion that happens. So for us, the touch point was this story, Val's story. I got a call from our colleagues in ADAC, and they basically said something has to be done, this is not good enough. So poor Val has intellectual disability. He also has a mental health illness. He has no understanding of the fact that he has severe dysphagia. And he presented to the hospital. His medical file was handed over at this time, and it had all that beautiful information. However, it was actually not acted on, as you can see there. Twice we had a near-miss episode of a choking because Val loves white bread cheese sandwiches, and any of you who work with dysphagia will know they are deadly. They turn into a gluggy mess, and but if you ask Val, do you want one? He definitely says, I want one. So we had to do something about that. So this is just some more of those statistics that Jackie has talked to you about, of what is the experiences of people with intellectual disability when they come to hospital. So we know that there are many more adverse outcomes during the hospital stays. We also know much poorer health outcomes, and Jackie talked to you about the gap in the life expectancy. I presented this project in New Zealand last year and was very dismayed to find that their statistics are absolutely the same. I think the gap in life expectancy is about 3 years more than it is in Australia. So it's not just us that are doing a bad job. I think it's worldwide. We know that our cohort has a large percentage of our cohort will develop a DSM-5 diagnosable mental health condition in their lifetime. Depending on the research, is about 40 to 60%. So that is really important to remember. We also know that, and again, Jackie has touched on this, unrecognised conditions. So a lot of my clients are unable to access standard health surveillance. So no breast screen, no dental screens, no bowel screening when they get to the age of 50. All of those things are inaccessible to them. So again, a lot of conditions are unrecognised, and when people present to ED, well, it's worthwhile noting, again, as Jackie said. And we know that a lot of conditions are misdiagnosed and poorly managed. And I'll turn back to what Margaret's story here, and I will actually quote what was said at the coronial inquest. So in the medical notes, the treating doctor wrote of Michelle, who was Margaret's daughter's distress, crying and moaning as a temper tantrum, and said that he suspected meningitis, but previous experiences with people with an intellectual disability had clouded his judgment. And so rather than order the standard treatment that you would have done for any one of us who presented, she was sent home with Panadol to die of an invading middle ear infection that caused a meningitis that led her to die in hospital a day later. It is not... So some of this is mentioned on this slide in terms of the factors that impact that quality of patient care. So some of it is limited knowledge about rights. So this project is very firmly based in the rights of people with a disability and in the Disability Inclusion Act and the kind of changes and adjustments that we're all being required to do in order to ensure that people with disabilities treated with the same dignity and respect as the rest of us. Some of it is limited knowledge, and that's what we've tried to address in this, is getting the right information to the right people at the right time in order to provide the right level of care. And some of these, sadly enough, are quotes from before we started the project, when we were interviewing staff within our local health district about their attitudes to people with intellectual disability, and these are direct quotes, which I find really distressing. So when one of our adults present to hospital, there are lots of challenges. Number one, communication barriers. A lot of our clients are non-verbal, or they, as Jackie mentioned again, will communicate in different ways. There are very complex behaviours, and one of when we run the training sessions that back up the introduction of the folder that we have developed called the A2D folder to address these issues. One of the things that we want everyone to take away is that all behaviour is communication. It's just your job to find out what is this behaviour trying to tell me. Hospitals can be very scary. Anyone with an intellectual disability, or not anyone, a large percentage of people with an intellectual disability over the age of 50 will have spent some time in a large institution. And so when we see clients in my clinic, we work from the basis that every one of them come from a trauma and abuse background. So, and the fact that coming into hospital may bring up some memories of past negative experiences, and that will impact on how this patient will act in the emergency department. And certainly a lot of them will be in pain and don't understand what is going on. So what was our aim? Our aim was this. We just wanted to improve the hospital journey. We wanted to try and do better. We wanted to try and make people feel that they were valued when they came into hospital, and that people wanted to look after them in a proper way. We started very small. We started with only introducing this project into the ADAC-run and funded group homes in our area, which involved 123 residents and 14 group homes. So the principle, I've already mentioned that. We're based on the WHO. We wanted a person-centred approach, so we involved paid support workers, family carers, nursing staff, medical staff, allied health staff, to look at how do we actually see the person. And the reason why we wanted all of these people involved is that for those of us who have worked with intellectual disability, we recognise that if it takes a village to raise a child, it takes a metropolis to look after a person with an intellectual disability. When you actually begin to look at how many people are involved in providing care and support, it is a huge amount of people, and all of them have a valuable viewpoint to incorporate. So it was done in co-design, and we tried to make it as easy and simple as we could. So what did we actually do? We actually developed a folder. Those of you who have been to UK may have seen the health passport that is used across there. There are very many different ways of communicating what it is that a person needs. So we wanted to make it as simple and easy as possible. So we worked with the staff in our local health district to say, what is the minimal data set that you want to receive when someone comes into hospital unaccompanied and you need to know something about them? So they incorporated lots of comments for us, Things such as, can we please have a photo of the person on the front page when they're well? So that we have a baseline about what do they look like when they're well, and it gives us an idea about how unwell they are. We incorporated blister packs. We've found with time that people would come in with a medication chart, but in actual fact what they were receiving of medication was different to what was on the doctor's letter, was different to what was on the medication chart. So these days we said, please slip a blister pack into the folder. It also has a top 5, and those of you who have worked in aged care or would know about the top 5. So we were allowed to adapt our top 5 to incorporate risks. So we found that risks such as falls and choking and especially risks around challenging behaviours were important to incorporate. But the top 5 that are included in this folder also gives the person's communication style, and it gives some as to what the person likes. So Val, for example, when his behaviour escalates and when he's unhappy, if you can sing him an Elvis song, he will de-escalate incredibly quickly. So we might include that, or we have a young man when he escalates, and he quite frequently comes to ED because he has quite severe seizures. If he wakes up and gets very distressed, I will say Sleeping Beauty, and he will give me all of the voice actors, the year it came out, and all of those things, and that will stop him. So the folder, all of the resources, and I'll talk about that again when we get to the website we now have, which is our toolkit. But all of the forms that were developed that are in the folders are now available as interactive PDFs. In addition to the forms that I've talked about, anyone can slip in such things as a meal management plan, a behaviour management plan, epilepsy management plan, anything that is relevant to that person's care. Back to the front page, one of the most important things for you guys in ED, and what has been the feedback from the staff in ED at St. George, is the fact that there is a number and a name of a person that can be contacted 24 hours a day with information about this person has been the most valuable thing. When we initially looked at the population who lives in supported accommodation, it is very often difficult to find people who you can talk to who knows the person. So finding and creating a memorandum of understanding there would be someone always at the end of a phone call should a person present to hospital was proved one of the most beneficial outcomes. So our key outcomes were that we've actually had a lot of unnecessary admissions to hospital no longer occur. And that is because people it's not because they fall less or don't develop, don't break their legs or whatever. It's actually because they get discharged in a way that enables staff to look after them so they don't bounce back. So this is about knowing about the person's living circumstances so that when you're discharging a person home, all of the framework that is required for them to be able to be looked after in that supported accommodation is in place. There's certainly an improved communication with the patient. So our folder also contains usually the common signs. If someone's communication strategy is Magaton signs, it'll include the signs, and I must use this opportunity to teach you the most important sign of all. I don't want timeout. What do I want, Jackie? Good. The reason why I want to teach you that is because we had a client in St. George who came in and had a perineal sinus operated on, and he came out of theatre with a catheter. Now, no one talked to him about the fact he had a catheter, and he had spent many, many, many years becoming continent and was very proud of the fact that he would now go to the toilet. So he wakes up and he has a catheter, and people keep saying, no, you can't go to the toilet, no, you can't go to the toilet. But they didn't explain to him that he didn't need to go to the toilet, and he kept doing this sign. And in the end, he actually leapt out of bed, ripped out his catheter, and we had him for 3 months longer than we otherwise would have had because his whole wound was torn to pieces. As part of the introduction of the folder, we've been doing education. So we've now done education sessions to doctors, nurses, and allied health staff. About 800 staff at the as we're talking, and those education sessions are still running. Those education sessions talk about the rights of people with intellectual disability. They challenge people to actually address their own attitudes towards people with an intellectual disability, their own fears around it. I'm quite happy to own up to the fact that I trained in intellectual disability and psychiatry when dinosaurs walked the earth, and I probably spent the first year of my training overcoming the fears that I had around people who I couldn't communicate with, who looked very different. And I think we just all have to acknowledge that that is the case, and that some tools and things can assist us rather than run away, and then that person in ED in particular being the last one that gets picked up from the list. Because that used to be the common problem at St. George, is that everyone would pick whoever they could, and the person who they knew had an intellectual disability would just be sitting there. So we've seen a lot of changes in attitude, and they're up there: listen to understand, establish rapport, addressing ID patients as people. Isn't it sad that I had to go and hold a talk about people with intellectual disability, and then that's someone's response when we ask them, what will you do different after this session? I would have hoped they talked to people with intellectual disability as people before that. Pay more attention to emotional needs and the needs of patients and their carers. This is a short video from one of our carers who have been part of this project.
The hospital admission for us is very stressful. I'm the carer of a young man who is 19. He has an intellectual disability. He has a lot of behavioural issues and he's non-verbal. So it's very hard for staff to communicate with him and to understand him and some of his signs and behaviours. Using the A2D folder helped us with that journey, that process, so that all his information is contained in one central spot. The A2D folder includes the Webster pack, which has all the medications, list of the medications and how he is to take them. That goes with the folder with him to hospital. The top 5 is like 5 simple ideas or strategies on how to manage someone with behavioural issues. And for Mitchell, one of his top 5s was to remind him or talk to him when he's eating, because he tends to shovel everything in at once, and he then is at risk of choking, which he has done on occasions. I feel confident now that I can go away at meal times and not have to be there, that staff can be reminding him of doing that so that he won't be a choking risk. We added in things like a behaviour support plan, his epilepsy management plan that we already have for when he goes to respite. We put that in the folder because we thought that was important for him. Having the A2D folder means that the journey for us, for him and for the staff is a lot smoother.
So that was what we were hoping for. So as said, we started off concentrating on some added group homes within our local health district. As the project spread, and it's now spread to Sydney Central Local Health District, the Blue Mountains, Nepean Health District, Port Macquarie was the last health district to take it on. We've also had a lot of requests around including community carers. And hence Anne was one of our first community carers to develop a folder for her son. To assist in people being able to develop the folder, we created the A2D healthcare website. On that website, and I can't take you to the website, I wanted to take you through. It's very simple, it's very easy to access. When you go in, there's a couple of videos. There's a video designed to tell health staff why it's useful. And it is spread into 4 different sections, one for family carers, one for disability support workers, one for health professionals, and one for people with an intellectual disability in simple, easy access. Oh, there it is. So you just scroll down. And here we go. So you can go into, fantastic. In Easy English is the folder for people with an intellectual, what have I done? An intellectual disability. Stop it. I don't know how to get rid of it. And okay, there we go. When you click into, for example, for health staff, in there, there's a lot of information that's shared, which is how to put together a folder. But for health staff, there's a whole lot of the policies that underpin the project, links to education, both from the ACI and intellectual disability, as well as ADAC provided online information sessions. Disability staff is the same, and for carers, we've just tailored it more around how to put together a folder. There's a video which actually shows how you assemble the folder. And in resources, all of the, so this is the video that tells you about, it is a conglomerate of 6 different scenarios that all came out of our local health district, and how, if the folder had been present, things would have been better. This is, I have to leave this up here because I'm so proud of it. This is Julian Stroller's endorsement of this folder. He's been a great supporter of the project because we work closely with him around all of the data around hospitalisation. And I'm pleased to say that we just completed the final evaluation before phase 2 of the project, and we have now proof that we've been able to reduce our length of stay from 5.75 to 3.2 days with the introduction of the folder for this population. So this is the data for the group of people who have the folder. They, over the last 3 years, have reduced their length of stay, and we're very proud of that. I'm also thinking that we have improved some of their hospital experiences. So here's what makes up the folder, the front cover, find out more, and you can click in and then we do the training. And this is for any one of you who might want to have some training or thinking about introducing the folder. We do clinical staff. We go around and do clinical staff training across New South Wales as it stands. So there you are. Now, how do I get out of it? It's showing my troglodyte here.
Do you want to go back to the presentation?
Yeah, back to the presentation. That's fantastic. Okay. All right. So I would like to finish with this quote, which I guess ties again in with whichever way you want to say speaking. Whether you speak in pictures or gestures. If you cut my hands off, I couldn't speak, I can tell you that, because I'm always gesturing. But I think this really says a lot about, and that's what we've been hoping to make a change with by having the folder as a way of allowing those people who do not have a traditional use of words to explain to us in the health profession what their needs are, so that we can provide those reasonable adjustments that are required to give the best care. And that hopefully, if I am still presenting in 10 years' time, we can say that we reduced the gap between the life expectancy by a lot. So thank you very much. Any information, you can email me on that email, or you can go to the A2D Healthcare and have a look for yourself. Thank you.
Questions, comments, or additions to that wonderful presentation on a wonderful project?
Thank you. Hey, have you had any conversations with maybe eHealth around getting this online and for people to use in the community?
No, we haven't. Hetty has done a small e-learning. Hetty has done a small e-learning module for us that is available, but it's again for health staff. So the big thing now is how do we socialise this to the community carers, who is a much bigger group than the support workers and the amount of people who live in supported accommodation. So we've got funding to extend to have a project officer, so that within our local health district we will now start going out to carer organisations and do presentations, assist carers to do the folders, and also to give them the links to the website. But we would love to take it further. But it is work that's additional to all our normal roles. Our team consists of 5 people. So it's a big job to get out there and speak to everyone. And within our local health district, you would all know what the turnover is. We run training sessions in St George ED on a monthly basis because of the number of staff that work in that ED and because of the number of turnover. Turnover has one positive thing. Hopefully they will go to another ED and talk about it. But at the same time, we have to continually provide the same education and training. Yeah.